for the
Thanks,
next
Ewan.
talk. Thank you, Ewan.
So much for your time. No, thank you.
Thank you.
Thanks.
Thank you. So our next talk is Dr. Matthew Huggett. He's going to talk on a novel therapy of EUS-guided surgical bypass in pancreatic cancer. Dr. Matt Huggett is a consultant gastroenterologist and hepatologist at Leeds Teaching Hospital. He has worked at and trained at all 4 major teaching hospitals in London and did the advanced fellowship at Newcastle Hospital and has done a PhD from UCL. Matt currently is a chair in the pancreatic section of BSG and is also an honorary secretary for Pancreatic Society of Great Britain and Ireland. Welcome, Matt, and you go live now. Thank you.
Thanks very much for that kind introduction. So this talk is meant to be slightly provocative in terms of how we can do EUS-guided non-surgical bypass in pancreatic cancer. And what we'll do is we'll go through a bit of data on the 2 particular techniques which I'm going to talk about, which is EUS-guided biliary drainage and EUS-guided gastrogenostomy. And I'll also talk through our experience that we have in Leeds. So first of all, EUS-guided biliary drainage, it's being increasingly used as a salvage procedure in tertiary centres. The issue with it is it does have quite a steep learning curve, but published data do show high technical and clinical success rates, with in the early studies an adverse event rate in the region of 7 to 37%. It is preferred in malignant disease, but we do sometimes use it in benign disease as well, particularly in surgically unfit patients. And there are a number of anatomical approaches, but 2 main ones which I'll go through. It's now in the ESG guidelines as an alternative to ERCP, particularly where ERCP fails, but there was a lack of randomized data until recently. In terms of the main approaches, one is intrahepatic via the left lobe of the liver from the stomach. And the main procedure that we do in this case is Herpasico gastrostomy, putting a stent between the 2. I'll show you a video of that later. But more importantly, we use extrahepatic drainage from the duodenal bulb into the common hepatic duct with a lumen-opposing metal stent, a Dokodenostomy. Why are we interested in this? Well, this was a study published last year looking at HES data for patients who are having percutaneous transhepatic drainage for those with biliary obstruction. About almost 2/3 had undergone a previous ERCP, so presumably in most of those it had failed. But the in-hospital and 30-day mortality rates of these procedures were very high, with a high complication rate. And as many of you will know, doing percutaneous transhepatic drainage is technically challenging. Patients are often in the hospital for several days, and they may need more than 1 percutaneous procedure to actually achieve drainage and insert a stent. And a number of patients were readmitted. Looking at some historical data, so this was published in 2017, it's probably the biggest meta-analysis of patients who had had EUS-guided biliary drainage and compared them to those who had percutaneous drainage. And it looked at 9 studies with nearly 500 patients. There was no difference in technical success between the 2 procedures, but EUS-guided biliary drainage was associated with better clinical success, fewer adverse events, and a lower rate of intervention, and was also more cost-effective. Most commonly now we use a lumen-opposing metal stent, the hot axis stent, which was mentioned previously. This was initially designed for drainage of pancreatic fluid collections, but now smaller sizes enable us to use this for EUS-guided biliary drainage, gallbladder drainage, and indeed formation of anastomosis, such as gastrogenostomy. We have experience of this. Manu spoke about our UK series of using the stent in pancreatic fluid collections. This was the first paper we published, showing that in pancreatic fluid collections, we had a very high technical success and clinical success and an adverse event rate of 11%. So we're used to using these stents. So this is a kind of dokodenostomy. First of all, you measure the bile duct, and ideally it should be greater than about 15 millimeters. You then see the hot axis stent being punctured into the bile ducts in a freehand technique, and then we often put a wire up into the bile duct for stability. The stent is opened, you then pull it back to oppose the wall, and then you release the other flange of the stent within the endoscope, and then you drop that into the duodenum, and hopefully you see a nice gush of bile with the formation of the dokodenostomy. Also, we have the ability to do Herpasico gastrostomies. This is the gearball stent, which is half covered and half uncovered. The idea is you put the uncovered section in the liver, so you can get drainage of the smaller bile ducts, and the covered section between the liver and the stomach, meaning that you don't get a bile leak into the peritoneum. This is a Herpasico gastrostomy, so we puncture the segment 2 or segment 3 of the liver from the stomach using an FNA needle, a 19-gauge FNA needle, and then we insert a wire and contrast, so contrast first to get a cholangiogram, and then once we've got a nice cholangiogram, we then, which you can see there into segment 2, we then insert a wire down towards the liver hilum and preferably distally into the bile duct. We then use a cystotome, this is a 6 French cystotome, to burn the hole a bit larger, and then we insert the stent between the liver and the stomach, leave 2 or 3 centimeters of stent within the stomach to allow for expansion of the stomach with food. You can, normally we carry out these procedures under general anesthesia. The patient needs to be very still, and we also need to do a number of exchanges during the procedure, and you don't want to lose a wire during this procedure. There you see the stent between the stomach and the liver, and that's the view retroflex. You'll notice some air under the diaphragm there, and it's very common to get slight pneumoperitoneum with this procedure. This was a study, and this is interesting, bear in mind what Ewan was just saying, talking about whether we should be doing EUS-guided biliary drainage or ERCP. And this randomized patients between one or the other for palliative treatment, but I'll mention why this may be useful in those patients who are having surgery. It was a randomized controlled non-inferiority study from Korea with 125 patients with a primary outcome of technical success. They allowed crossover between the groups, and neither the technical success nor the clinical success was significantly different. What they did find, though, was that the procedure time and hospital stay was shorter with the EUS-guided biliary drainage with a lower rate of adverse events, and this was driven by the 0 rate of pancreatitis in the EUS-guided biliary drainage group. So in those patients who are having surgery for pancreatic cancer, you can negate any risk of pancreatitis, post-ERCP pancreatitis, with the use of the EUS-guided biliary drainage, because you go above the pancreas for the drainage procedure. But interestingly, they also found a lower rate of adverse events, particularly in terms of stent blockage. So there was a higher stent patency rate in the EUS-guided biliary drainage group. We're currently getting together our data from the UK, so 8 centres in the UK and Ireland. We've done 120 patients using dokodenostomy with a median follow-up period of 70 days. We've got a high technical and clinical success rate of these procedures. The adverse event rate is 17.5%, of which 2 were classed as severe, and I'll go through the adverse events in a second, and 8% needed re-intervention. But interestingly, out of these 120 patients, 9 patients then went on to have a successful Whipple's resection for cancer, so that's something which needs a bit more exploring. I don't know how well you can see this, but dividing the complications out into mild, moderate, and severe, the mild ones tended to be the ones that either there was a bit of pneumoperitoneum because of stent maldeployment, but they were rescued procedurally without any clinical consequences. We had a couple of cases of, or several cases of cholangitis, which were treated with antibiotics. But then in the moderate cases, some of those cases of cholangitis had to be re-intervened on. And our practice now, certainly in our centre, is to insert a double pigtail stent within the hot axis to try and prevent any blockage of the lumen basal metal stent. There were, however, two severe complications, both of which required laparotomy, which I think should not be sort of undersold. These procedures are risky. If something does go wrong, it tends to go badly wrong, and these patients, had to undergo surgery. So we need to be doing these procedures very carefully. In terms of the EUS-guided gastrogenostomy, you will know this study, quite a small randomized study from a few years ago in Holland, which concluded that those comparing duodenal stents to surgical bypass, that despite slow initial symptom improvement, gastrogenostomy, i.e. surgical, was associated with better long-term results and is therefore the treatment of choice in patients with a life expectancy of 2 months or longer. Because stent placement was associated with better short-term outcomes, this treatment is preferable for patients who are likely to survive less than 2 months. So that's what our experience is, really. Patients who are who have a short life expectancy get reasonable relief with duodenal stent, but they're not brilliant. So laparoscopic gastrogenostomy should be the standard of care, but patients are sometimes surgically unfit, so we do usually put duodenal stents in those, but duodenal stenting does have a poor functional result. The other issue is if you have extrinsic obstruction, for instance, something like a retroperitoneal sarcoma or something like that, the stents can migrate, and if those patients aren't fit for a surgical gastrogenostomy, then we need to be thinking about other techniques. So EUS-guided gastrogenostomy with a luminous metal stent is an alternative. It's more feasible with the development of the 20 millimeter diameter LAMs, but data are really limited to case reports and series, and the techniques, there are at least 5 different techniques, and we don't yet know which is best. So this is a video of how we tend to do gastrogenostomy. You can see this is a patient with a distal gastric cancer who's actually already had a duodenal stent in, which was not functioning properly. So we put a normal endoscope down, we insert a wire through the stricture into the jejunum. What we do then is we insert a nasobiliary drainage catheter, and we connect that up to a foot pedal and pump so that we can infuse water into the jejunum. We then remove the endoscope and then put an echo endoscope down. You can see as we're flushing water in with the foot pedal, the jejunum is inflating. And we can use screening as well to confirm position to inject contrast down the jejunal tube. We then check for vessels, and we use the hot axia system to puncture into the jejunum. And you can see there, using the cautery device, which is part of it, and infusing more water as we go. You then puncture into it. And then much as with a pseudocyst, you then open the flange, which you can just see it opening there. You then pull it back to oppose the lumen. And then you open the other flange within the scope. What we do as well is we put methylene blue into the water mixture so that actually when you do release the stent, you get a nice gush of methylene blue so you know you're in the right position. This is a study comparing gastrogenostomy. Again, this is retrospective versus laparoscopic gastrogenostomy. The efficacy was similar between the groups, but they quoted a lower rate of adverse events in the EUS-guided group and a lower procedure cost. This is I think we've done over 20 cases in Leeds now, but when we last looked at this, 80% were for malignant etiology. We've done, I think, 1 for chronic pancreatitis as well. The technical success rate was good. The one that failed, we did the same session duodenal stent instead. All patients tolerated at least a liquid diet without vomiting before discharge, and 9 patients who were on PN pre-procedure were successfully weaned off. There was 1 adverse event due to maldeployment stent with a gastric perforation, but no jejunal perforation. And what we did is we just closed the gastric perforation within the same session. and then inserted a second luminous metal stent without any clinical problems. And that really is the main concern with the EUS-guided gastrogenostomy of stent maldeployment. This is a multi-center study which we've been involved in recently, which is as yet unpublished, but the manuscript has been written. And 467 procedures amongst 8 US and 8 European centers. There were 46 cases, so about 10% cases of stent maldeployment. Of those, 61% were mild, 24 moderate, 13 was severe. And they go through in the paper actually how they're defined, but 2 cases were fatal. Now, 83% of all maldeployments were managed endoscopically, but of the maldeployments, 11% required surgical intervention. 9% went to ITU, and of the people who were doing these, 73% of the maldeployments occurred in the operator's 13 procedures. So this just demonstrates the learning curve associated with this procedure. But whereas some of these patients would have had duodenal stents possibly in the past, it just shows that this can be a catastrophic event and should not be undertaken too lightly. So in terms of, in conclusion, I think there's going to be an increasing use of advanced therapeutic EUS with using these techniques in everyday clinical practice, but there is a very steep learning curve and we don't know how training should occur. The adverse event rate is not insignificant and can be devastating if that is to occur in a patient. And clearly we need MDT input to develop workable pathways and more data from randomized trials. So we obviously need a very good team of endoscopists and nursing staff to do this, and open for any questions. Thank you.
Great. Thank you. Matt, that was fantastic as expected, and thanks for the great videos as well, because it really just helps understand just where we're going with endoscopic therapy now. I know the team at Leeds have been leading this the interventions so well, and we've got a question here from Mike Mitchell. Says, is there any plans for a prospective trial of EUS bile duct drainage now from the sort of the data you're getting from the other centres, and because it may provide some extra governance protection for us all. Where do you think we stand on setting that up at the moment?
Yeah, so we've done a prospective study which has just been accepted to GIE with the Nottingham group, actually looking at quality of life data as well, which so that's been published. There are, I think, 4 randomized studies which are going on around the world at the moment, so it'll be interesting to look at those data. But really the thing that interests us at the moment, which we're quite keen to set up, is actually a surgical study where actually we can put these in, or look at putting these in versus the RCP in patients who are going to go on and have neoadjuvant treatment and then surgery, to actually see if we can reduce the rate of pancreatitis and then hopefully get patients through their pathway quicker.
The ones you're using to create the gastroenterostomy now, is that a 2 centimetre wide one, or can you get away with a 15 millimetre one?
We've used the 2 centimetre wide one for all of them. I don't know why. I don't think there's any need to use a 15. I think.
Yeah, I think that's the problem with other devices. I realise there's one you showed there, but other metal devices aren't that wide at the moment, which I think is causing a problem in the uptake of the hot axis, which is another question that's just come through. Matt, thank you ever so much for your time. As you're well aware, Steve's after you, and he's on a tight time scale as always. So we're going to get him. We're going to get him